Welcome to our bronchiectasis question time webinar. My name's Pippa Powell. I'm the director of the European Lung Foundation. Unfortunately, I'm having to step in today for Dimitris Kontopidis, the ELF chair, who unfortunately couldn't join us today due to health reasons. So this is one event in a whole series of events taking place around the world for today, which is World Bronchiectasis Day. And I'll mention a little bit more about that later. But first, I have a few housekeeping bits of information that I need to share with you. So Wordly, we have an automated translation tool for you to use today, and you're able to access that tool using the QR code at the top of this slide, or you can click on the link that's just been put into the chat, and that will take you to the Wordly app. The Wordly app has the potential to translate this webinar into 50 different languages, and you can choose the language when you enter the app by using the drop-down menu. Wordly will open on another screen, and you can position that next to this webinar so you can read the transcript as we go through the session. Apologies that the translation won't be perfect, we know that, but we hope it will really help you in trying to understand the session today in your own language. This event is in a webinar format, so throughout the course of the event, you'll be able to see all of the speakers and panelists, but we unfortunately won't be able to see you. You can, however, interact with the panelists throughout the session by using the chat function and the Q&A. If you've got specific questions that you would like answered by our experts during the course of the webinar, please put them into the Q&A. The chat is more for comments and interacting with each other. We'll try and get through as many questions as we can throughout the course of the webinar, but any that we're unable to answer live, we will try and answer after the event. This event is being recorded, so if you miss a bit or you want to go back and listen to it later, it will be available to access on the ELF website. If we go to the next slide, so today is a day for World Bronchiectasis Day. It's really a day to try and help raise awareness of this condition and to reduce the burden of bronchiectasis for people living with the condition and their families worldwide. So as you can see from this slide, there is a coalition of many partners, organisations who are working together on this day to try and raise awareness of bronchiectasis. There is a website, which again is being placed into the chat, where you can access information, resources, and see some of the other events that are going to take place today and over the course of this week. If you plan to post on social media during this webinar, please use the hashtag World Bronchiectasis Day and tag us at ELF, the EMBARC, CRC, the ERS, and the COPD Foundation. You can see the Twitter handles, if you know what such things are, on the side of this slide here. So at European Lung, EMBARC Network, EuroRESP-SOC, and COPD Foundation. So it's my absolute pleasure at the end of those housekeeping slides to be able to hand you over to our host for today, Barbara Crossley, and she's going to take us through this session expertly, as she always does. So over to you, Barbara.
Thank you, Pippa. And welcome to everybody watching and listening. We've had a fantastic amount of interest in this bronchiectasis question time, so I hope you find it useful. My name is Barbara. I'm a patient from the UK, and I've had bronchiectasis since childhood. I'm now in my 70s, and I like to think I'm living proof that you can have a long, happy, and active life, even with severe bronchiectasis, which I have, though you do have to work at it. Bronchiectasis is a condition defined by abnormally wide, damaged and distorted bronchial tubes, which are prone to infection. In many cases, but not all, it means we produce excessive mucus, which is hard to clear. Unless we get rid of this mucus using airway clearance exercises, we risk flare-ups of infection. Now, we've had a huge range of questions beforehand, so we've classified them into different themes. And as well as listening to the answers from our panel, you can also, as Pippa explained, put written questions in the Q&A box to be answered by our expert behind the scenes. So now I'll ask our panel of experts to introduce themselves. And first is our patient representative, Anu.
Thank you very much, Barbara. So my name is Anu Kuusisto, and as Barbara just mentioned, I'm also part of the patient advisory group. I am from Finland, and I was diagnosed with bronchiectasis about 4 years ago.
Thanks, Anu. Now I'll go to Michal.
Hello, good afternoon. My name is Michal Steinberg. I'm a respiratory expert. I'm a physician from Haifa, Israel, and I'm working in bronchiectasis and adult CF. I'm a part of the EMBARC management, and I work together with the European Lung Foundation, or ELF, to coordinate the projects of the Patient Advisory Board. So I'm thrilled to be here.
Thank you, Michal. Now we'll go to Peter.
Hello, my name is Peter Middleton. I run the cystic fibrosis and bronchiectasis clinics in Westmead in Sydney, and currently I'm actually visiting James Chalmers in Dundee in the lead up to the World Bronchiectasis conference later this week.
Thank you, Peter. Now we'll go to Jessica.
Yes, hello everybody. My name is Jessica Rademacher. I'm a respiratory physician and infectious disease specialist. I work at the medical school in Hanover in Germany. And I do the bronchiectasis clinic and antimicrobial stewardship for the whole hospital.
Thanks, Jessica. And now to Stefano.
Good afternoon, everyone. My name is Stefano Aliberti. I'm a chest physician from Milan, Italy. I'm running I'm the director of the pulmonary department here in Humanitas Hospital, and I've been involved in bronchiectasis care since many years. And it's a pleasure to be with you all this afternoon.
Thanks, Stefano. And finally on our speaking panel is Danielle.
Good afternoon. My name is Danielle. I'm the lead respiratory physiotherapist in Carmel Hospital in Haifa, and I work with Professor Steinberg in bronchiectasis and CF mainly.
Thanks, Danielle. And now I'll ask our Q&A man answering your written questions behind the scenes to introduce himself. Over to James.
Thank you very much. Lovely to be here. So my name is James Chalmers. I'm a professor of respiratory medicine in Dundee in the UK. I'm a clinician looking after people with bronchiectasis, and also do a lot of research, including as part of the EMBARC European Bronchiectasis Network. So please put your questions in the Q&A and I'll be delighted to try and answer them for you.
Thank you, James, and thank you, everybody. So now, without further delay, I'll ask our first question to set the scene, really. And this is one for Peter. It's about the causes of bronchiectasis. Is bronchiectasis a disease from birth, or is it a consequence of another disease? Over to you, Peter.
So thank you for that question. It's quite a good opening question, really. And as Barbara outlined, bronchiectasis is defined as pathological and permanent dilatation of the airways. And there are lots of different causes, including genetic disorders such as cystic fibrosis. But then people without cystic fibrosis can also develop bronchiectasis later in life. People with immunodeficiencies can have bronchiectasis, people with severe infections, autoimmune diseases, and for a lot of different reasons, bronchiectasis can gradually develop during childhood or adulthood, but only become clinically significant later in life. So it's really a spectrum of causes for bronchiectasis.
Right, thank you. The next question is for Jessica. Can COVID-19 trigger or start bronchiectasis if you didn't have it previously?
Yeah, thank you very much. This is an interesting question. Theoretically, any pulmonary infection can trigger bronchiectasis. So we all know post-infectious bronchiectasis after severe infection in childhood, or like severe infection with influenza, tuberculosis, or pertussis. However, after COVID-19, fibrotic progressions after the infection is more described than bronchiectasis changes. So at now we have not so many severe COVID-19 pneumonia in not immune suppressed patients. So I think this will be not very often. But I think it's very important that all bronchiectasis patients are fully vaccinated and they have the annual refreshment of the vaccination.
For COVID-19?
Yes, for COVID-19.
Okay, thanks. I'll put the next one to Michal. Can bronchiectasis be cured? This is what we all want to know.
Yes, that's a really nice question. I'm really glad to have it. And well, for the first part, bronchiectasis clinically or symptomatically can be improved very, very much. And this is relating to our symptoms, to the rate that we have exacerbations or flare-ups. So we can really feel a lot better with bronchiectasis. Regarding cure, until recently, we would say, no, bronchiectasis is a chronic disease. It can't be cured. We would have to work all our lives and keep treating patients or their lives in order to prevent symptoms and to prevent infections and to prevent flares, because the distortion of the airways will always be there once it has started. But just recently, there has been a few reports of very, very early bronchiectasis that may actually be reversible. So it's not the common thing to see. It's just a minority, and it's the very, very early stages. But it's really exciting data to see and very encouraging. So we think that in the very early stages, it might be possible to reverse bronchiectasis totally. But in all of the stages, even in advanced bronchiectasis, we can certainly make our patients feel much, much better.
So when you talk about reversal, does that really apply mainly to children rather than to adults?
It does. It applies mainly to children who have the very early stages of bronchiectasis. There has been a report in patients with cystic fibrosis that have been starting to get treatment with special drugs for cystic fibrosis called modulators, that a small minority may also have reversibility of some of their bronchiectasis. It's really early reports, but they're encouraging. And we mainly speak with bronchiectasis, we mainly speak of children with very early disease.
Exciting times, yeah. So we had the most number of questions on the subject of sputum. So that's our next category, which we'll go on to now. And the first question is, I'm going to put to Danielle. What is the range of volume of sputum that people cough up? And what's the average amount per day? In other words, how much do people with bronchiectasis spit out each day?
So this really varies, because some people have what's considered a dry bronchiectasis, and some people are obviously very, very productive. EMBARC registry suggests approximately 1 teaspoon up to half a cup of sputum per day. But again, it's very patient specific.
Right, so it varies a great deal. Yeah.
Yeah.
So Danielle mentioned dry bronchiectasis there, and it's a subject that we haven't touched on very much before. So we've had a question about airway clearance in the case of dry bronchiectasis. Should you still try to do airway clearance to reduce the risk of infection when really you're not producing much sputum at all?
That's an interesting question. There's really no evidence to suggest one way or the other whether airway clearance is effective in dry bronchiectasis. There are a couple of points that I think are really important though. Do you actually have dry bronchiectasis, or is your airway clearance not effective, first of all? Because I think a lot of patients feel they have dry bronchiectasis, but actually their airway clearance techniques are not very effective, or they are not doing the correct airway clearance technique for them. And in this case, I think it's really important that they have a review by a specialist physiotherapist, and they review their airway clearance techniques to see that they are doing them effectively. Do them for a couple of weeks, a month, and really see that they have dry bronchiectasis before they stop doing them, because they want to make sure that they're not missing something. They may actually have a lot of sputum, they just are not aware of how to clear it effectively. I've seen a lot of patients recently that have told me they have no sputum, and when reviewing their airway clearance, actually we've managed to cough up quite a bit.
Oh, well, that's good to know. Yeah. But I happen to know that our patient representative, Anu, does have dry bronchiectasis. So what's your answer? Do you do airway clearance, Anu?
Yes.
Yeah.
Absolutely. I mean, I think that was part of the reason why my diagnosis took such a long time, and nobody could really even think that it might be bronchiectasis. Because I only tend to get that sort of small amounts of sputum, especially if I've eaten something or had a hot drink. But I do air clearance every single day, minimum 3 times a day. And I use the positive, the PEP device. And I do notice, because my left lung is worse off than my right lung, that when I do that and I start the huffing, I do get small amounts out. Obviously, it's not like your typical, very mucousy type of bronchiectasis, but it also helps me, have a normal life, because it was like night and day in terms of how it was before I was diagnosed and before I started using the PEP devices, because I was so tired. I was running a fever. Now I don't really get flare-ups that often anymore, and I don't really get sick that often, and I don't really get those mucus plugs there that really make me out of breath. And I felt like even in midwinter, I had to open the window because I wasn't able to breathe. So I would say absolutely yes, even those with dry bronchiectasis, it does help you. So highly recommended.
Oh, that's great. Thank you, Anu. So at the other end of the spectrum, this questioner says he or she has 2 major discomforts: a persistent cough, especially in the evening, which leads me to no longer have a social life, and the other, a large daily production of phlegm or sputum or mucus. And I'm going to put this to Peter. Is there any medicine to fight both the persistent cough and the large daily production of phlegm? And is there any cough medicine that actually helps with the bronchiectasis cough? So over to you, Peter.
Well, thank you for that question. I think it's important to say that the amount of sputum that is produced on a daily basis really represents the clearance of the mucus from the lungs. And normally we produce about 100 to 150 mils of sputum without bronchiectasis. This is in the normal situation, but we're not aware of actually clearing that mucus from the lungs. It just happens automatically. So the sputum that we expectorate is actually an excess above the amount that can come out of the lungs normally. Doing physiotherapy, and as has been said already, effective physio really requires a specialist physiotherapist who can use all the different devices, whether we're talking about the positive expiratory pressure device, the PEP, whether we're looking about flutter or any of the other techniques that are available, it really requires a specialist going backward and forth to actually maximize the clearance of the mucus from the lungs. Then it becomes a question of working out whether there's superadded infection and whether some mucolytics are required, long-term antibiotics, either oral or inhaled, or other therapies that may be necessary to really address the ongoing mucus production. And in that situation, everyone should be working with their physio and their doctor to try to optimize their therapy.
When you say mucolytics, that means a mucus thinner, basically, isn't it?
Yes, so hypertonic saline has been used for a number of years, and some people will develop irritation of the airways with hypertonic saline, so it needs to be used sensibly, again in concert with the physio and the medical teams. For cystic fibrosis, we can use Dornase alpha, and some people will also use Mucomyst or other inhalational agents.
So this question is asking if there's any cough medicine that will help with a bronchiectasis cough.
Well, really, yeah, the problem is that most cough medicines are actually cough suppression agents. So they don't actually stop the mucus being produced, they just stop you responding to the fact that it's down there. So cough suppressants actually are not a good idea in bronchiectasis. It's actually much better to actually treat the mucus that's down there and ideally to remove it and to remove any infection that's down there.
Yeah. Okay, thanks so much, Peter. I'll put the next one to Mikhail. Does an increase in sputum quantity and colour always mean an infection, even if the sputum test comes back negative?
Well, that's really an interesting question. And we have to, like Peter said, know where the sputum is actually coming from. And a lot of sputum, especially if it's a darker color like green or brown, represents inflammation of the bronchi. Usually, when there's inflammation, there's always also infection, which means bacteria or bugs in the lungs. They usually go together. But the darker color of the mucus, of the sputum, comes from actually the inflammatory cells of our own bodies that are there to fight the infection and the inflammation. So usually when there's dark sputum and a lot of sputum, there is infection and inflammation. Sometimes the laboratory result comes back negative, which means there's no bacteria. It doesn't mean absolutely that there actually isn't an infection, because we know that laboratories don't always report all of the bacteria that are actually in the lungs, in the bronchi. There are some bacteria that may be there in small quantities, and the laboratories don't detect them very well. Sometimes there's bacteria that the labs don't actually identify. And sometimes there's inflammation without bacteria, without infection. And I think it's one of our challenges in the future to tell apart which exacerbations or which events are actually caused by bacteria and need antibiotics, and which may resolve without. As it is currently, we do treat exacerbations with antibiotics. It helps us if there is a lab report showing that there is one bacterium or a dominant bacterium or a dominant bug, but we treat with antibiotics anyway, just in case there are bacteria that we can't really identify.
Okay, well, This next question I'm going to put to Jessica, and it's on the same subject really, of sputum tests. The questioner says, we cannot get a sputum test result fast enough to help determine the appropriate antibiotic. In my case, says the questioner, I may need 4 rounds of various antibiotics to kill off the bugs. This is most likely causing my body to become resistant to antibiotics. How can we get rapid sputum test results? Jessica.
Yes, thank you. So at first, it is important to get regular sputum monitoring in stable disease, to have the knowledge of the last sputum result during an empirical therapy. So when you have an exacerbation, the sputum test is not fast enough to start with an appropriate therapy. We always have to use the empirical therapy. So it is important that you have a result from the stable time. And then we often divide between patients with Pseudomonas aeruginosa and without Pseudomonas aeruginosa. And the next thing is that we have only very limited substances available for oral antibiotic therapy, because it is very important that we have a good bioavailability of the substances. For example, cephalosporins are not really good because the bioavailability is not very good. So in patients with Pseudomonas, we start empirical with fluoroquinolones. We just have the ciprofloxacin and the levofloxacin. And when we have no Pseudomonas aeruginosa, then we can take an aminopenicillin with a beta-lactam inhibitor. And then it is good in case of an exacerbation that we take a current sputum, and then we can focus the therapy in order of the disease. So maybe 2 or 3 days later, we have the result of the sputum, of the recent sputum, and then we can make a focused therapy for the patient. For the standard of the sputum examination, that's not really easy, because we need a good microbiological labor. And in Germany, it is that we have to do the microbiological workup according to the cystic fibrosis standard. So we observe the culture for a longer time than for standard patients or standard microbiological workup.
Right, thank you. But is it contributing to antibiotic resistance, do you think, the delays in getting the sputum test result?
Yes, a bit, because when we have a broad spectrum therapy, then we have more antimicrobial resistance. But we only have some antibiotics in oral care that we can use. So I wouldn't worry too much about these 2 or 3 days, because we have to treat a bit broader, because even when we have the sputum results and then we have the pneumococcal, we are not sure that there is any Pseudomonas making the disease more severe. So we have to take not too thin antibiotics. We have to do a bit broader.
Okay, and related to this question, there's one on what you call hemoptysis and what we patients call bleeding from the lungs. This questioner says, when I get a flare-up with bronchiectasis, my lungs always bleed, sometimes a little, sometimes a lot. He or she says I hit it fast with an antibiotic, as it's the only thing that settles it. But my question is, are there any other treatments coming down the line to help prevent bleeding?
Yes, as far as I know, there's no medication coming up to prevent hemoptysis in the pipeline. But the basic therapy of bronchiectasis has a high priority. And if hemoptysis occurs frequently, I would be rather like maybe caution with inhalation with hypertonic saline, or inhalation with inhaled antibiotics like aminoglycosides. So hemoptysis is often occur during an exacerbations, and antibiotics are important to treat the exacerbation. The other drugs you can use in case of hemoptysis is tranexamsäure or epinephrine to inhale. So we have some drugs you can use in case of bleeding, but I know nothing that can prevent it. But I think a good basic therapy is very important to prevent hemoptysis.
Yes, I found this when I had quite a severe problem. Last year, I gave up inhaling hypertonic saline because it was inflaming my lungs. And I took quite a cheap tablet. It's called tranexamic acid. And it worked. It stopped the bleeding. So that was fine. Yeah.
Yes, that's what I meant. I'm sorry, I said it in German. Thank you.
Tranexamic acid.
Yes, tranexamic acid. Yes. All right.
Okay. We had quite a lot of questions about the devices that people use to aid mucus clearance. The flutter devices, aerobica, a cappella, those kind of things. Are there, well, some people find it quite costly to use these things because they have to be renewed at various intervals. Is there any alternative to costly devices? Danielle, you're the physiotherapist. Do you know of any alternatives to what they call the PEP devices or the vibrating devices that some people use?
So I'll start firstly with, there's very little evidence to say airway clearance with a device or without a device is more effective than the other. The evidence is really inconsistent. In clinical trials, there has been really little difference in airway clearance with or without a device. So if you're finding it really expensive, there is obviously an option to look at finding an airway clearance technique without a device that's effective for you. Alternatively, you can use really, really basic things that most people have at home. Again, there's really no clinical evidence to say it works. Patients find that it's very effective. I have here, it's a box, I don't know if you can see. Can you see in the camera? It's just a basic injection thing that we use often for saline, and you can use that through exhalation as a form of PEP, and they cost next to nothing. They can be washed with soap and water. Most people have them very accessible. It does add some exhalatory pressure, so it's a really basic form of PEP. Alternatively, we've got things like water bottle with a straw, and you can blow bubbles into the bottle of water. So your exhalation you do through the straw into the water, and that also adds some resistance to exhalation. So again, it's a very basic form of PEP, and it doesn't cost very much money. So they're just two very, very basic things that you can use on the low cost level.
Oh, that's great. Thank you, Danielle. Yeah. People do seem to be worried about antimicrobial resistance. And perhaps I'll put this one to, well, it's back to Jessica. For those of us who grow multiple different types of bacteria, such as Pseudomonas, MRSA, strep pneumonia, are we more likely to suffer from antibiotic resistance? And is it made worse as we're told to start rescue meds before receiving sputum cultures back? So are those with multiple infections more likely to have antibiotic resistance, you think?
Yes, so many patients worry about antibiotics and about multi-drug resistance pathogens, and I understand that worry, and I run the antimicrobial stewardship team in our clinic, and we try to avoid too much use of it. And of course, the more antibiotics are taken, the higher is the risk of developing resistance. But I think in patients with bronchiectasis, it is a bit different because exacerbations are often complicated by bacterial infections. And without antibiotics, the outcome is mostly worse. And in case of exacerbation, it is important to start a rescue therapy. But it is true, when you often take antibiotics, then you have a higher risk of resistance pathogens. But I think the a bigger difference is sometimes from country to country and not from disease to disease. So I think it is important that everybody care about antibiotic use and that we don't use it too often. But in patients with respiratory diseases, we sometimes have to use it. It is really important, and in some other patients group not.
Okay. I'll put this next one to Stefano. Should bronchiectasis patients try to fight off lung infections without antibiotics? And if yes, how many days do we go before we start? And I think that one's talking about antibiotics for use when you've got infections. There's a follow-up question. So can bronchiectasis be managed without long-term antibiotics, which is the macrolide antibiotics that many of us take either every day or every second day? So there are two questions there, really. If you've got an infection, should you try to manage without the antibiotics? And can bronchiectasis be managed without long-term antibiotics?
Thank you, Barbara. Thank you, Barbara. And good afternoon, everyone. Concerning the first question, the answer is yes. If there is a flare-up, if there is an initial exacerbation, what we as physicians, but also our respiratory physiotherapist colleagues are suggesting is to increase the airway clearance across a couple of days, because some of the exacerbations might be controlled thanks to the increase of airway clearance. Because if I increase the sputum going outside of my lung, also pathogens are going outside, right? So my inflammation in the lung is going down, and I might control or even get rid of the exacerbation, some of the exacerbations. So the take-home message is talk to your doctor, but in the majority of the case, you need to increase the airway clearance during the exacerbation. If in a couple of days this is not enough, then the majority of physicians tend to prescribe antibiotics in order to get rid of the exacerbation. Concerning the second question, I think that with respiratory physiotherapists and with an optimal management with other drugs or interventions, we might also avoid to have all the patients with bronchiectasis under macrolide therapy, right? So macrolide, long-term macrolide treatment should be on top of the management of the disease, at least when airway clearance and exercise tolerance are optimized with a good adherence and under the supervision of a respiratory physiotherapist. However, we know that a portion of our patients needs to underwent long-term macrolide treatment to control symptoms and the rate of exacerbations.
Yes, I must say, sometimes if I have an infection, it does go away after a couple of days of increased airway clearance exercises. So it's worth a try just for a couple of days to see if it goes away. And I do take long-term antibiotics, so, and it's fine. I have no problems with that. The next question I think is one for Mikhail. Many lung lung infections are viral, but antibiotics are used with bronchiectasis as the main treatment option, which of course is antibiotics are aimed at bacteria. So do viral infections become bacterial with bronchiectasis because the bugs get trapped in the lungs? Can viral become bacterial? The questioner asks.
Yeah, that's a great question. And actually, to understand it, I think we need to say that there are 3 kinds of bugs, of pathogens that can infect our lungs. There's viruses, which are very, very small and usually don't infect our lungs for a long period of time, but just for short periods, like when you have a flu or COVID, and then it usually goes away. There are bacteria, which are larger bugs and can live independently, and they grow for long periods of time in our lungs, and unfortunately, they're stuck there for people with bronchiectasis, and the lungs are infected with bacteria for a long period of time. So usually, and this is really relating to what Jessica said before, that it's really worthwhile to know previous cultures, because usually the bacteria that you had is there also right now when you have an exacerbation. And the third kind is fungi, which are very rare, and they're a rare cause of infections. So usually we have a long course and a chronic infection with bacteria. And on top of that come a virus. And there has been research that says that about 50% at least of exacerbations are caused by viruses. And the virus usually creates more inflammation and also probably wakes up the bacteria. So there's no really good explanation to the mechanism why it happens, but the viral infection encourages the bacteria to do more harm in the lungs. And usually we don't have good treatments for viruses, and we do treat the bacteria. So in the future, maybe we'll have more treatments, such as anti-inflammatory treatments. But now we treat the bacteria that are going up as a result of the viral infection. So it's really very complex. I think we just are starting to understand the relationships of the different pathogens or bugs that we have in the lungs, what the relationships are between viruses and bacteria. But we know there are such relationships because it's a very valid question. Why do we treat with antibiotics that work on bacteria only when the cause is a virus? And antibiotics don't work against a virus, just against the bacteria. So the answer is probably the virus is doing something to encourage the bacteria, and this is why we treat with antibiotics. But it's a great question.
Great, thank you. Thanks, Michal. So one of the long-term infections that we get is, of course, Pseudomonas and sinusitis. I'll put this one to Stefano. What is the normal course of treatment when you're first infected with Pseudomonas? And why may you still get flare-ups even when you're nebulizing antibiotics for 3 months? What's the normal course of treatment in that case?
So we know that when Pseudomonas is isolated for the first time in the sputum of a bronchiectasis patients, the majority of us tend to suggest a treatment with a systemic antibiotic and with an inhaled antibiotic for 3 months in order to, let's say, eradicate Pseudomonas, or to give or to try to have the patient free from Pseudomonas as longer as possible. So this kind of intervention is suggested by guidelines according mainly to expert opinions, because strong and solid randomized control trials are not there for this kind of question. However, observational data in clinical practice are suggesting that we want to do that because we want to have the patient free as long as we can from this bug. In case of sinusitis, this might be a little bit more difficult, although Pseudomonas seems not to be the first pathogen giving chronic infection in case of chronic rhinosinusitis, but is still there and and we might have more difficulties in the eradication treatment in case of persistence of Pseudomonas in the upper airways.
Right. So there's not much you can do about that if it persists in the sinuses.
What we do is to discuss the case with our ENT, with our colleagues looking after patients with chronic rhinosinusitis, and understand if, in addition to nasal lavage, there might be surgery as an important intervention to clear the sinuses from mucus and from bacteria. So there might be an individualized indication for surgery for specific patients with chronic rhinosinusitis and bronchiectasis.
Right. As patients, we do a lot in terms of self-care. Anu, I know you are interested in the self-care, which includes exercise as well as airway clearance. What kind of exercise regime do you have?
Well, it depends. I mean, my preference is to do anywhere where I can get my heart rate up, because I feel the more exercise I do, the better I feel. And I can now remark on the fact that I haven't done a lot of that type of exercise in the last month because a lot of the classes are on summer break. And I do notice that my lungs are starting to get more congested, so I've had to really up on my airway clearance. But I think any type of exercise is good. And obviously people have varying levels of bronchiectasis. I am probably on the end where it's considered mild, even though it's widespread. And hence I sort of try to push myself to do a bit more each time. But even walking, I try to walk half an hour each day, because I know that it's good for my lungs, it's good for my joints, and it's a very easy type of exercise to do. So it's if you just walk to the shops and walk back, for example, it's just something that you can do quite easily.
Another one I do is I go up and down the stairs 40 times.
Yeah, that's also a very good one, and it can leave you quite breathless afterwards. But it's good, whatever feels good.
Yeah.
Yeah.
As long as your family don't think you're mad.
Yeah.
I have a question about another infection that many of us have, which is NTM. That means non-tuberculous mycobacteria. It's more common in some parts of the world than others. It's pretty common in America, particularly, I believe. So, Peter, I have this question for you, for people who have NTM as well as bronchiectasis. If you have mild symptoms and through the years your CT scans show some progression, are you doing more damage by just keeping a watch rather than go on the 3 prescribed antibiotics that can do as much damage to your body?
So thank you for that question. Australia, unfortunately, is fairly hot and fairly humid, so has a lot of environmental mycobacterial species. And there are a whole bunch of different types of non-tuberculous mycobacteria. And unfortunately, they're in the soil, they're in the water supply, they're everywhere. And it is one of those things where the decision to treat or not to treat is actually quite a difficult one. The difficulty is that mycobacteria divide relatively slowly, so to actually eradicate them or to kill them, you actually need months and months of antibiotics compared with Pseudomonas, where even a few days can make a difference. So the decision to actually embark on treatment depends both on the individual patient, the deterioration that is being associated with that mycobacterial infection, and also whether we've optimized the physiotherapy, because mucus clearance techniques are critical here to actually get on top of the bacteria, these slow-growing bacteria that occur inside the lungs of only some people with bronchiectasis. If you do decide to treat, then it is a long and arduous course of treatment, and different subspecies of mycobacteria have different combinations of antibiotics, and many of the combinations do actually have significant toxic reactions. So it's really a case of, first of all, maximizing your exercise, maximizing your airway clearance, and then working out with your doctor whether it is worth your while to actually have a course of treatment for this non-tuberculous mycobacteria. So it's really a very specialist derived decision and is a long course of treatment, and unfortunately is associated with some side effects in the long term.
Yes, and this the 3 prescribed antibiotics, do they have to take them all at the same time or in sequence?
It depends on the exact type and the subspecies. So Mycobacterium avium intracellulare complex versus the different types of Mycobacterium abscessus versus some of the rarer mycobacteria such as Gordoniae, Cheiloniae, and some of the other ones. So really it is multiple antibiotics at the same time. Some of my patients have required 3 months of intravenous antibiotics. So they had a long line put in and they had to put up intravenous antibiotics which ran continuously for literally 3 months. So it depends on the exact species. Many of these bacteria are really quite resistant, so they need combinations for a prolonged course.
Okay, thank you. Could I put this one to Jessica? This is about fatigue, bronchiectasis and sudden fatigue. What are the reasons that we get fatigue, and is there any advice to manage it?
Yeah, so fatigue is a really big problem in patients with bronchiectasis, and we have no really good therapy. So the first question, why do patients have fatigue? I think it's because of the chronic inflammation in the lung, and that makes fatigue. And we know this symptom from the patients with NTM, with non-tuberculosis mycobacteria. They often have fatigue as a major symptom, and bronchiectasis without NTM have also fatigue. So I have no solution for it. I think it is important to make regular physiotherapy, regular inhalation, to like Anu said, go out and make a walk and meet with other patients. But there's no therapy specially for fatigue.
Okay, so we're looking towards the future now, and hopes of new treatments coming down the line. I'll go back to Peter for this one. When can we expect to be prescribed the new anti-inflammatory brensocatib, and will this be available privately before it's available through the normal health authority channels?
So thank you for the question. Brensocatib is the first, hopefully, of a number of anti-inflammatory agents that will be useful for bronchiectasis. It works in the long term by lessening the neutrophil elastase, which we think is an over-exuberant inflammation within the lungs. And the trials that James Chalmers has prioritised around the world have already shown that there's good improvement in the number of exacerbations and the quality of life. The exact time that this gets approved and gets reimbursed in different countries will really be dependent on those countries themselves. But really, it's one of those things that the ongoing trials are continuing to show benefit, and hopefully brensocatib will be the first of many agents in this area that will show benefit for people with bronchiectasis.
Has brensocatib shown any side effects that we should worry about? I know other anti-inflammatories have an effect on the liver or the stomach. Should we be worried about that in taking it in the future?
There haven't been any particular.
Oh, I'm sorry.
Sorry?
The connection just broke up a little there. Could you repeat what you said, Peter?
So there aren't any major side effects that we've seen in the trials for brensocatib, but James may want to comment because he sees the.
Okay, can we go over to James to answer that one?
Yeah. So Peter's breaking up a little bit. I'll jump in for a moment. So yeah, the trials haven't shown any problems with liver toxicity that I'm aware of. And obviously any new medicine that comes onto the market will be monitored very carefully for any unexpected side effects. But actually the side effect profile looks very good. In terms of when the medicine's likely to be available, the company's announced that they're planning to launch in the US in 2025 and in Europe in 2026. So hopefully not too long to wait, assuming everything goes to plan.
Oh, that's great. Thank you so much, James. And that seems a good note to end the session on. And thank you so much, everybody, for contributing so informatively. We really appreciate it, but I think time's run out on us. There are plenty of sources of information online, which will be shown on your screen shortly. And I particularly like to draw your attention to the Bronchiectasis Self-Care Guide, produced by us patients and approved by physicians, and it's available in 13 languages on the EuropeanLung.org website. So I hope you find all that useful, and I'll now hand back to our director, Pippa Powell. Thank you.
Thanks so much, Barbara, and thanks to all of you for an amazingly informative session. I've learnt loads myself, and I hope everyone else has who's online. Thank you for all the hand claps and the comments and the questions that you've made throughout the course of the session. So as Barbara mentioned, there's a whole range of resources that we hope can help you on your bronchiectasis journey. Here at the European Lung Foundation, we have a bronchiectasis hub. And as Barbara already mentioned, we have the fantastic Bronchiectasis Care Guide, which is really, information from patients for you, developed together with the healthcare professionals. So we really recommend that you read that. We also have lots of other information on our hub, and we really invite you to go and have a look. Let us know if things are missing and let us know if there's languages you want that information in. There are other sources of information, and we just want to highlight 3 of those. One is from the COPD Foundation, and they have done a range of materials for World Bronchiectasis Day, which includes a new fact sheet on bronchiectasis treatment. Lung Foundation Australia have a bronchiectasis toolbox that you may want to have a look at. And finally, the EMBARC registry, which is so key and vital to all of this amazing research that's taking place for people living with bronchiectasis. Please do go to the EMBARC website and find out more about the great work that's happening as part of the EMBARC activities. So finally, I just want to thank everybody for this session today, all of you for attending, but importantly, our amazing panelists with their fantastic questions and answers. So thank you to Anu, Stefano, Jessica, Danielle, Michal, and Peter. And thank you to James behind the scenes, frantically typing away, answering all the rest of your questions in a week that is incredibly busy for him with the launch of the World Bronchiectasis Conference later this week. And finally, Barbara, as ever, a superb host, really ran the event beautifully. So thank you for leading this today. And I hope you have a great time at the World Bronchiectasis Conference later this week too. So great to stay in touch with you all. Please do follow what ELF are doing. We'll have another patient conference, I'm sure, at the beginning of 2025, and we look forward to seeing you there. So thank you, everyone, and have a fantastic evening.